So let's go to the triple negative subtype. So just another very simple explanation why we call triple negative. And I know that many of you don't like this wording. We don't like it either. We think that we should be defining something by the presence and not by the absence of biomarkers. Nevertheless, so far, what we consider triple negative breast cancer is the cancer that does not have the hormonal receptors, the estrogen and the progesterone receptor, and also does not have this HER2 receptor. So because they don't have these three receptors, the tumor, we call it triple negative breast cancer, okay? So far, it has been defined by the absence of biomarkers instead of by the presence of biomarkers. However, and I know this is a complex slide, but it's just to tell you that this is indeed just like a box where we put everything that doesn't have the estrogen receptor and the HER2 receptor. And so there are plenty of subtypes within the triple negative. And the biggest research around triple negative, besides obviously defining new treatments, is to understand these different subtypes. And there are different classifications in 10 subtypes, in 7 subtypes. But the objective, my objective here is to tell you that the future is to classify not as with the absence of receptors, but with the presence of some biomarker in all these subtypes that will allow us to use that biomarker as a target, okay? For the moment, this classification that you see here is not yet ready for our use in clinical practice. And also because it's mainly done with what we call genomics. What you see on your left is what we call a genomic array. So it's a lot of genes, some in red, some in green, that allow you to classify these subtype in different subtypes. And we cannot use this in clinical practice because it's complex and is expensive, okay? But the research is on defining different subtypes within the triple negative disease. There is something else that I took some slides off because I didn't want to overload you with information. But when we call triple negative, we are referring to a specific histology of breast cancer, which is the ductal. Now it's called non-special type, but before it was called ductal. And so I'll make just a parenthesis. There are many different breast cancers that many of them are these triple negative, but they are in fact different diseases. Like, for example, metaplastic breast cancer is a triple negative, but it's a different one. And I don't know if any of you is there that has these special subtypes of breast cancer, but these are really a separate type of disease that I can answer questions if any of you has. But I didn't include it here. So we are talking here about the most common subtype of breast cancer, that is the ductal breast cancer. So one characteristic, unfortunate characteristic of this subtype of triple negative is that they are complex tumors who usually respond less to every line of treatment. So you can see here that traditionally, what we could use to treat these tumors is chemotherapy, and that at every time they would respond less time. So first 12 months, 9 weeks, 12 weeks, 9 weeks, 4 weeks. So less and less to the different lines of treatment. And they have, in general, the worst outcome. It doesn't mean that it's always like that, but it's very often like that. And when we look at the available options to treat this subtype, you will see that the vast majority of options are chemotherapy options, right? So we have different agents that target the microtubules. You see there the taxanes, eribulin, vinorelbine. We also have different types of anthracyclines, other agents such as capecitabine and platinum that are very important agents specifically for this subtype of breast cancer. But in the last 5 years, more or less, maybe a little bit more, we have started to have some targeted agents also for this subtype. And I will mention these 3 targeted agents: the PARP inhibitors, the checkpoint inhibitors that are a type of immunotherapy, and one specific antibody drug conjugate that I already explained to you what it is, and that has a complicated name, as usually they do. So deruxtecan is already difficult to say. This one is sacituzumab govitecan. So it's on purpose so that we cannot say these words properly. Anyway, let's start with the most common treatment for triple negative, which is chemotherapy. And sometimes we are very unfair with chemotherapy, you know, because first we say that it's always very toxic. Not true. And that it's not targeted. Well, it's also not true, because the target of chemotherapy is the cell cycle. So if you guys remember when you went to high school, you studied that a cell enters in the different stages of the cell cycle until it develops and divides into two cells. So the target of chemotherapy is this cell cycle. So it means that chemotherapy kills the cells that divide quickly. And that's why it is linked to certain types of side effects. So if we think, what are the cells in our body that divide quickly? Our hair. It's always growing, right? And that's why it is one of the side effects of chemotherapy is affecting the hair, also affecting the nails, because the nails are also growing all the time. And another part of our body that is always regenerating is the gut. So since all the digestive tube, the cells of the mucosa are always regenerating. And that's why you also have nausea, vomiting, diarrhea. So these are the reasons why you have those side effects, because chemotherapy kills the cells that divide quickly. And finally, another cell that divides very quickly is the white blood cells, the cells in your blood that are responsible for protecting you from infections. And that's why sometimes we have fever when we have chemotherapy, because we are less protected against infections. Now, what I wanted to say more about chemotherapy is that this is a study, a meta-analysis, looking into many studies that compare one agent of chemotherapy versus 2. So a combination versus a monotherapy. And what they have shown clearly that you can see here is there is no benefit on giving a combination of agents. And this is probably one of the most common mistakes, if you want, of many oncologists, is thinking that if they give you 2 things at the same time, it will be more aggressive and therefore more effective. Not true, okay? There is no benefit in survival, not even in PFS, which is the time without progression. There is a more rapid response, but it doesn't translate into a better control of the disease. And so for the vast majority of situations, what we recommend is to use one agent at a time. Also because that allows you to have more options. Like I told you in the beginning, it's so important to have different lines of treatment. So if you use all at the same time, you are out of options faster, right? So this is one of the most important messages. And it's regarding triple negative, regarding HER2 positive, and hormonal dependent tumor. Anytime we need to go for chemotherapy, let's use our treatments wisely, one at a time, for as long as we can use each treatment. Okay. Then I also wanted to discuss a couple of things with you. So told you that the goal is to improve the duration of life, survival, but with a good quality of life. So a couple of points. Toxicity is crucial. And I have to tell you that among all the different types of chemotherapy, there are no huge differences in efficacy, but there are many differences in toxicity. And we need to discuss, and you need to discuss with your oncologists and also tell other patients, advocate for other patients to discuss with the oncologist, what is the side effect that you want to avoid? An example, let's say that you use your hands for your profession. You play the piano, or you build something with your hands, or you are a surgeon and you need your hands for your profession. You don't want to have what we call neuropathy, which is and affects the nerves on your hands and feet. And then you are almost unable to grab things and to perform, for example, drawing is a big difficulty. So that will be one side effect that you want to avoid. There are patients for whom losing the hair is something they don't want to go through it. It's very important. For others, they tell me, I don't care about my hair, it will regrow. But for some patients, they just don't want to face that. And so there are different side effects from different chemotherapies, and we can choose and adapt the chemotherapy to the side effect that you want to avoid. It's not all the time like that. It depends on how many options we have available, but it's many times like that. And we don't need to use always a taxane that gives you neuropathy and alopecia, so losing your hair, when you can use something like capecitabine, that it's an oral drug that does not make the hair fall down, doesn't give neuropathy. It has other side effects, but probably more adaptable to most people. So toxicity and patient preferences have to be really well discussed. Something else that is fundamental is dose reductions. And again, I cut here some slides, but there was a very interesting presentation 2 years ago at ASCO by a patient advocate from a survey done to metastatic breast cancer patients regarding dose reduction. So she asked, would you be willing to discuss with your oncologist a reduction of the dose so that you can tolerate better the treatment? And an overwhelming, almost 90% said yes. And they also said that when they discussed toxicity, because they had a side effect, the most effective way to reduce that side effect was the dose reduction. And I don't have the time to go into a lot of details, but I can tell you that the majority of treatments that we use are given at too high doses because of the way we've been developing treatments. And so in the metastatic setting, we don't need to use those high doses. And we can certainly reduce the dose and make the treatment more tolerable, so that it is better to be able to receive the treatment for longer than to have to stop because we're forcing a very high dose that it's too toxic. And the last point about this is about using oral drugs instead of intravenous drugs. So for the majority, there is this idea in some patients' minds that drugs that are given intravenously are more effective than drugs that are given orally. That is not true. And so the effectiveness of a drug is not linked to the route of administration, okay? And so just because the chemotherapy is oral, it doesn't mean that it's less effective, okay? It has different side effects, but it is much more convenient that you can receive an oral treatment, you take it home, and you don't have to come so often to the hospital. One parenthesis here to tell you that that's something that we need to keep on lobbying and advocating for. In many countries, oral treatments are not reimbursed as much as IV treatments. And so in some countries, the physicians have a lot of pressure from hospitals not to prescribe oral treatments. So we need to fight together for that not to happen. And my final points about chemotherapy is to tell you that there are new ways of giving old drugs. So we know that there are old drugs that are very effective, but they have some side effects that we want to avoid. For example, anthracyclines are one of the most effective drugs in breast cancer, but they do have a small but present risk of toxicity to the heart. Now, one way of giving them is to put them in these drops of what we call, what can I explain here? They are drops of lipids, let's call it this way, where you can put the drug and it passes through the liver and goes straight to the tumor. So it is more targeted and less toxic. It doesn't affect the heart. It is also more expensive, and that's why it's not so widely used. And one way of giving treatments or chemotherapy that we are using now even more than we used to do, it's not a new way, it's an old way actually, but we have reusing it very often these days, is what we call metronomic. So what does this name means is that we give lower doses more frequently. So for example, we can give a low dose every day instead of giving a big dose and then having to wait 3 weeks to be able to give it again. And this way of giving, so low doses very frequently, it's called metronomic, but it's also very effective, and it's also effective against the vasculature, the irrigation of the tumor. So that becomes very active against that. It's a complex concept, but it's important to know that that seems not at all aggressive, it's quite efficacious way of giving chemotherapy. So that's what I wanted to say about chemotherapy. Now, what about then the targeted agents that exist for triple negative disease? I'll start with this type of immunotherapy that it's called checkpoint inhibitors. And what you can see here in these figures is another receptor, right? I explained to you about the HER2 receptor. This is another receptor. And these receptors are important for our immune system cells that you see there called T cell. So T cell is a type of white blood cell. And these are our immune system cells. This is very important for the immune system cells to link to the tumor cell and attack them. Now, just a parenthesis. Another characteristic of the cancer cell, besides the ones that I told you, they are immortal. They proliferate very quickly. They can invade the blood vessels and the lymphatic vessels. They can also hide. They are experts in hiding from our immune system. So our immune system doesn't recognize the cancer cell as something that it has to destroy. And what this type of treatment does, it's presenting the tumor cell to our immune system and telling them, look, this is a bad cell, you have to kill it. So they kind of put a sign in the cancer cell saying, bind here because this is a bad thing and you need to kill it. So that's, in a very simplified way, how immunotherapy works. What it does is really to call the attention to our immune cell that they need to kill those tumor cells. And that's why they potentiate this link between the tumor cell and the T cell or the immune system. So one example of these agents is pembrolizumab. So pembrolizumab links to this receptor called PD-L1, okay? And when the PD-L1 is well expressed in the tumor cell, and we give pembrolizumab together with chemotherapy, we will see, this was the study that has shown that. Again, the separation of curves that you see here. So showing that providing the pembrolizumab together with chemotherapy is more effective than chemotherapy alone. It has side effects. So again, even the targeted agents have side effects, different side effects, but they do have side effects. On the top, you see the most common side effects, like chemotherapy-like side effects. And these are acceptable. You don't see a lot of patients having to drop the treatment, just about 20%. So less than 1 in 4 have to drop the treatment because of toxicity. But then there are other types of side effects from immunotherapy that we call immune-mediated side effects that are more specific to this treatment. They are less frequent, but they are more severe. And I have an image here to tell you there are mostly inflammation of different organs. So very frequently they affect the thyroid, but they can also affect the lungs, like with the pneumonitis, or the colon with enterocolitis. So there are a lot of things that are inflammation because of the activation of the immune system. Now, what are the recommendations? So we say that, because I didn't show you all the data, but the pembrolizumab has also shown to improve substantially the PFS, and also probably, we still don't have the final results, the overall survival. There is another agent called atezolizumab that has a more conflicting data with 1 positive and 1 negative trial, or 1 sort of positive and 1 negative trial. So now it's not that we are against its use, but if you have access to both, the results with pembrolizumab are stronger. Now, moving to the other type of targeted agent, this is the PARP inhibitor. So let me try to explain. PARP is a protein that is involved in the mechanism to repair our DNA. So don't look at the upper part of the figure. Let's focus on the lower part, on the right part of the slide. When we have an hereditary breast cancer, so we have those breast cancer genes, the BRCA, what happens is that our cells have a deficiency in the mechanisms of DNA repair. And when you see the tumor cell is particularly sensitive to this BRCA deficiency. So imagine a table that you have that doesn't have one of the legs, right? So that's what you see in the lower part of the figure. So that's a tumor cell with a BRCA gene, a breast cancer gene deficiency. If you hit another leg, the table is not able to stand, right? And so that's what the PARP inhibitor does. It hits the other leg and makes the tumor cell die. Why is it targeted? Because in the normal cell, they still have the 4 legs. So even if with the PARP inhibitor, we break one of the legs, the table is still able to stand. And that's the difference between the tumor cell and the normal cell in someone who has an hereditary breast cancer. Okay, not sure if it was understood, but that's why these agents are very well tolerated, and they are effective only if there is this BRCA mutation. Okay, so the way we have studied these agents in breast cancer was to compare these PARP inhibitors with chemotherapy, because that's what has always been our standard of care. And we have two of these agents, olaparib and talazoparib, and they gave very similar results with a good difference in the progression-free survival, so time without progression. But unfortunately, these trials were not well designed, and they were not sufficiently powered to show the overall survival benefit. So we don't know if we can improve survival with these agents. They are also expensive. And this is something I'm sure Richard Sullivan will discuss with you about the cost of all these agents. So this is the same results for talazoparib that was for olaparib. So this has led to the recommendation that it is a very good option for triple negative breast cancer associated with BRCA mutation, because they delay progression, have a improved quality of life as compared with chemotherapy. And I'm going to put this recommendation here. I'm not going to go through it, but you can read it. And if someone is under this circumstance that has another gene that it's called PALB2, I'm happy to answer any questions, because these agents also work for the PALB2 mutation. So if you have these two options, imagine that you have a hereditary breast cancer, BRCA mutated breast cancer, that is also PD-L1 positive. So which one do you use first? So they have not been compared. And so what we are recommending here is based on the results that I showed you. And because we see an overall survival benefit with the immunotherapy, we tend to prefer immunotherapy first and PARP inhibitors after. It doesn't mean that it has to be like that for all patients, but it might be like that for the majority of patients. Last type of targeted agent is then another antibody drug conjugate. You see there is another antibody. It is not trastuzumab in this case. It's called sacituzumab. So it's an antibody against another receptor called TROP2. And again, as you see here, there are these red dots. These are chemotherapy drugs that go within the antibody transported to the interior of the cell. So this is called the sacituzumab govitecan. And this was very interesting because it has shown almost 6 months benefit in survival. So it adds 6 months of life. It does that to patients who have received multiple lines of treatment also before. So at least 2 lines of treatment, which is very important for the triple negative since we don't have a lot of options. But it does have toxicity as well, especially diarrhea, nausea, vomiting, fatigue, and also loss of hair. So it has to be a balance, and it's very important to use prophylaxis. I'm not focusing too much on side effects, but I know you will have a workshop to focus on this. And the most important message is for side effects is try to prevent when there is the possibility to prevent, and also manage early. Don't let the side effects run for a long time. Try to attack it as early as possible. So this has now become one of the preferred treatment options for triple negative disease, but it is extremely costly as well. So conclusions for this part, I think I've showed you the importance of high quality pathology. Also told you that there are many subtypes, although we can still not use them in the clinic. What is useful here is hormonal receptors on HER2 because it helps define triple negative, PD-L1, and the BRCA gene mutation. Chemotherapy is still the main treatment for triple negative, single agent better than combination, and now these three types of targeted therapy, immunotherapy with checkpoint inhibitors, PARP inhibitors, and this antibody drug conjugate called sacituzumab. So we have seen for the first time some benefit in overall survival, particularly with immunotherapy and sacituzumab.